The idea is not to have these in isolation, but see how you can pull together and synergize from these particular effects. One of my great mantras is there should be no research without capacity developing, and no capacity developing without research. And so often we see those two things separated. Somebody's sent to do training, but on a topic that might not be relevant to research that's actually needed within their own country. Or research in the country is needed and we bring in a team from the outside to address this. So trying to put these things together and make sure that we have a coherent whole. I got slightly worried then. I looked over my shoulder and there's a 20-foot high version of me here. It's kind of disconcerting. So let me take you then to the WHO. And this year we've studied on the new general program of work. This is essentially the 5-year strategy of WHO. And the real push from the DG is addressing this triple billion burden. And the aim is that within the period of this strategy, there will be 1 billion people less at risk from health emergency, 1 billion people enjoying better health and well-being, and very importantly, 1 billion more people enjoying universal health coverage. Now, these are big challenges, and particularly in terms of universal health coverage, and we need to understand a little bit more how we're really going to get to that kind of figure. And from TDR's perspective, the world has changed. So when we started on neglected tropical diseases, it was pretty easy to find them. You just looked in a geographical band across the world. These were also the most neglected countries, the lower income countries. You could trace these down. But the world evolved. And even with neglected tropical diseases, this year, more than half of all people with a neglected tropical disease will be in a middle income country. So what we're looking at now is no longer neglected diseases, but neglected populations, often within countries that have reasonable income or have elevated into to middle income. And this has challenges, because if you want to reach with universal health coverage, these are the people we need to reach. These are the marginalized people, and they're not clustered together in countries, although 1 or 2 countries still do have some of these issues, but they need to be sought out and are often marginalized by society within other countries. So how then do we start building the sort of research that makes sure that implementation goes down to this level and everybody benefits from universal health coverage? These are just a few random figures of some of the challenges to achieving universal health coverage and the interventions. I mean, you look at figures like this, only 1 in 4 people with multi-drug resistant TB get on treatment. 3 out of 4 miss out on treatment. Across sub-Saharan Africa, about half the children with fever actually go to a trained medical provider. And a third of the 1.6 billion people at risk of NTDs didn't receive preventative treatment in 2017. So these are massive challenges, and if it was easy to reach into these populations, we'd already be doing much better. And what we need is solid research to find out what are the roadblocks and how we can improve this intervention. So what about the solution to this? Well, obviously concentrating the research on questions that transform health delivery. And we've heard within this particular forum, we're talking about implementation research, we're talking about operational research. But I think sometimes we get a little bit too hung up on the terminology that is around these things. Really, we should be starting to define this about what it does rather than the methodologies we use, and use tools all within our toolkit to try and fix these things. So really what we're talking about here is research that's conducted within real-life situations, and it's about really trying to give the evidence that supports scale-up and improvement of health services. And whatever we bring in that, call it operational research, implementation research, health systems research, or just tools along the way to the end point. Let's not get hung up on our definition. Let's look for our commonality. And the commonality is the cause of better health implementation at the point of the poorest populations. We've evolved over the 40 years, and there are quite a lot of us biologists in this room, and there's one fundamental truth in biology: if you don't evolve, you go extinct. And I think the important thing is that you keep looking at where you can best service and best provide services. So we started out very much creating tools. We still have the record as the best product development partnership, I think, with 13 products of anybody else, even though we don't do this anymore. But what we realized pretty early on is that developing products was not enough if they were not getting delivered within the context of the country and making an impact in the populations that we desired. So as you see, over time, our strategy has really pushed very hard towards access and implementation science. And our current strategy is wholly about looking at the science of solutions, about looking at how we can make sure that we provide solutions for the roadblocks against health, and how we can develop capacity in people within countries. Another really important point about implementation research for me is that if you're doing discovery research, you can prove that principle anywhere. You can be in a lab or in a university anywhere, and you can find out whether something could work. If you want to find out whether it will work, you've got to put it where it's going to be applied, which means you need to be in the country, which means you need to create local capacity to try the interventions and make sure that they're adapted and adopted to local conditions. And this is what we've been giving a great deal of thought to in our planning. And I'm not going to run through this rather complicated internal diagram, but I think just the takeaway of this is that there's a whole spectrum of different research, and there are a whole spectrum of different people who can contribute to that research from different points, whether that's going from lead researchers in academia to people embedded within the implementation arms of health services. So what we've been thinking about is how we best service this spectrum of activity, how we can best try and create an ecosystem of research around implementation. So I'll take you through a few of the things we have been doing. Any of you who were in the session here before lunch will already have seen this, but we still think it's very important to be training people at a master's level to be able to create this kind of research and go out as researchers and add that research to the program, no doubt about it. What we've done though is we've shifted away our model from it. Maybe 10 years in the past, we would have taken people from disease endemic countries and sent them all north, given them masters or PhDs, and then brought them all back into the system. But what we realized are two things. One, often your education is not in the context you're going to apply the skills. And the second is, you're going to have to do that forever unless you start investing in the capacity of the institutions within those countries to do it. So now we've transformed into trying to deliver our postgraduate training through these 7 centers distributed across the globe. And you saw some of the excellent students who'd been graduating through a little bit earlier today. The second thing we realize is that even people who are doing research, often there's no real ongoing support in terms of updating them on issues like research ethics or good practice in research or data handling and these kind of things. So we've set up 6 regional centers to try and do these short course curricula to support research and to try and give continual education. Now, 6 centers across the whole world doesn't seem very much, but this is a hub and spoke model. So if we take the example of CDIM in Colombia, we now engage with it, we work with the others to get the curriculum together, but they then connect out now into 26 different nodes around Central and Southern America that they've created by themselves very entrepreneurially, which means that we can assist in getting good quality material into the center, but it moves out. And this was very organic. People from Ecuador came to the first courses on ethics, went back using the materials established in Ecuador. Then when the people from Guatemala wanted to learn ethics, they went to Ecuador. And then from Guatemala into Bolivia. And suddenly you've got this kind of organic growth of the material coming out and proving very popular, but meaning there are centers which people can look to and get this kind of engagement training. And one of the reasons we're using this, one of the purposes for this is, of course, to push very hard our tools for implementation research, and particularly things like the massive online open course. It's been very, very popular. We started this about a year ago, and we had around 400 or 500 people showing interest at that time. The last registration was 6,000. And we've now translated into Spanish and French, and we're likely to be, I think, training this year probably near 20,000 people by these vehicles. So there's fantastic opportunity in this. But sometimes just sitting and doing this by yourself can be quite challenging. So engaging you in networks and using the regional training centers to provide support and mentorship has proved very, very popular in terms of creating a community of education with these. We have actually just been talking with China as well. It's very interesting. So I've got very conscious of 1 billion, so I figured if we get China, we've got 1 billion already, so our numbers will start looking very good. But there's an incredible appetite out there. The interesting thing about the MOOC is it's not created in a very theoretical way. You won't sit there and find you're getting lectured from a blackboard by somebody at the London school or the rest. Each of the modules is run by a practitioner who's using implementation research to improve their own health program. So it's actually worked around real life examples in this way. The other very successful tool we've been using is the implementation research training kit, and you see a copy out. It's available online. All of these tools are completely open access, completely free to access, and as with anything else that's coming from TDR. So again, this helps people to dip in and find out a little bit more. So one of the modules on here, for example, is in communication and advocacy. And we're finding that when people are taking this module, rather than, they're not the researchers, but they want to understand about communication. They want to understand about these aspects. So very important to support. So you see, starting to bring that support from purely academic to spreading out to support existing researchers, to reach out to people interested in whether they want to become researchers. But the last couple of examples I want to give speak back to a little bit of what I was saying last night on the panel for those of you there, is how we engage then down into the point of the implementers. And without doubt, our most successful scheme over the last few years has been this structured operational research and training initiative. This started in collaboration with the TB union and was about trying to improve the use of routinely collected data to improve programs for TB delivery. It's turned out to be a fantastic model that's extremely flexible in terms of the content. So now we've done it on everything from TB, HIV, NTD, antimicrobial resistance. We've got people doing it on NCDs. We've got people doing it on WASH. Because at the heart, it's about how people look at routinely collected data, frame research questions around that have an immediate feedback into the policy of where that data was collected. So you've got the program manager who has problems of distributing bed nets or getting bots out to where they want. Using their own data, they come up with solutions that can improve this. And we've been finding that somewhere in the region of 70% of the people who take these projects on are able to translate them into action within their own programs very quickly. And even in the last year, there were up to now 80 odd publications on here. But a couple of interesting things is then you can see the drive. These are authored by the practitioners. So over 90% are authored not by researchers but by implementers who are doing research. And around 70% of these are recording a change in practice. So it's a very immediate cycle of research into change. The other interesting thing is we find that people then realize the value of that research. Often, I've been in many health centers where people are recording in books. And you ask them why are they doing that, and they say because the health department asks us to. No real understanding of it. And I've been in health centers where I've looked and said, that's very interesting that exactly the same people came in on Thursday as came in on Wednesday. And the health center orderly would have a shy smile and said, well, it was market day, but if I don't write things in my book, we don't get our resources, so they go in. And this is the data that has been feeding up. And then no matter how complex your meta-analysis becomes, unless that data is better, then you get bad data at the end. And in fact, by teaching the collector to be a user of data, you massively improve the quality of that data that's coming through. One of the examples I'll just use from this is one of the students on the course who was trying to improve outcomes in TB treatments in Moldova. And so there have been some ideas about maybe introducing cash and vouchers for food because people were not able to afford to come to the clinic or were going hungry at lunch. So a very simple implementation research project is trying amongst the group and seeing whether a small incentive that would pay for bus fares and lunch fantastically improved the rates and has now been adapted across the TB control program. So a very small project, not very complicated, but had an immediate effect that's gone across the country for the small amount of implementation research. The final thing I want to talk about is reaching beyond the routine health services as well. And we became aware, just the number of stories of the people who set up, midwives going out on bicycles into villages, or school teachers who started doing malaria diagnostics in the classroom. And you hear all of these stories around. But then you often find out that these really good ideas don't get scaled up because there really isn't the evidence to sell this and to fund it and to move it forward. And we thought we might have a place here. So unusually for researchers, we thought we might listen rather than talk first. So first we thought we'd try and find out what this thing was, this social innovation. And because it was an innovation, we also took a quite innovative effect ourselves, because we did this through crowdsourcing. So we put out a crowdsourcing call for innovators, and then we picked up from over 200 submissions about 40 social innovations that we went in and did case studies on. And the idea here to look at what was happening and where there might be an opportunity for research to enhance this and push health into these cycles. And we found very much so that the key to this was keep your hands completely off the innovation. Innovation comes from anywhere, from anybody, in any place. But often the innovators were hitting a wall at the point that they wanted to scale out, and we could maybe be assisting them in some way. At first we thought this was a very simple solution, that we just put together the innovators with researchers, and the researchers would tell them how to do a study, and it would be great. I was at a workshop in Malawi not only a year ago. This is happening quite quickly. And I had two of the innovators in tears at my particular group, with these well-intentioned academics telling them how they could do this trial, this randomly controlled thing, doing this. And they had their hands going, but I'm so busy just trying to do my job. And so what we thought would be good was actually to create support centers where people could go and ask for the level of help they want. And for some, this is they want to do the research themselves and they want some assistance. For others, they want to link in with academics who may be able to help them get this data. So now very quickly, we're spreading to this network of support centers that are going around the globe. And really turning out to be a very successful approach. So it's a very hands-off. We're facilitating this rather than pushing it. And in fact, it's moving away from us quite quickly, which is excellent. They're starting to form their own groups, their own steering groups, and we are now coming back into the position of just trying to assist where necessary and then join in a partnership with expertise. But I'll show you from these small innovations the kind of power of this. And this is the health center by phone in Malawi. So in one district, which had a lot of difficulty reaching out into the community, and they realized they actually had very good mobile phone coverage. So they set up a health center by phone, a toll-free hotline, where when you call in, you spoke to a health worker. And that health worker would use the algorithms and the clinical guidance that was normal for the country, but it meant they could be accessible without the waiting around for hours in a different thing. We went out and we assisted this group to do some of the basic evaluation and some research around this. This scheme is now covering the whole of Malawi. So from one idea in one district, just getting enough evidence to go to the Ministry of Finance and Ministry of Health. We just heard this is going live across the entire country now. So, these innovations can really build up, but need our help as well. And we need to build capacity at all levels to do this. So my last slide. So the world is changing, but there are some fundamentals still there, I think. And if you hold on to those core values, I think you continue to do well. And I think we've continued to do well because of this. I think what we focus on is improving the health of the most vulnerable populations, those that are least served by the existing health systems. A commitment not to using the people in the field as a subject of research, but working side by side with them and trying to understand their needs and trying to answer the questions they are asking rather than giving them an answer we feel they should be hearing. Really important. I heard one of the questions a bit earlier about how do you make sure that implementation research gets taken into policy. At its heart, it's very simple. Answer their questions, not your questions. And it really gets taken up and it really moves forward. And finally, I think that this evidence, while is not sometimes as sophisticated as the studies we might talk about, it has to be high quality. It's absolutely got to have the quality that means you can base a decision that is going to change treatment and maybe change people's lives on that. So let's try and push together and make sure that capacity is developed across this whole spectrum and make sure that the real power of implementation research gets to work for these people. Thank you very much.